In Pakistan. We all are here with another webinar of APPNA MERIT Healthcare Research and Innovation Landscape in Pakistan webinar series. Today, we are very happy and privileged to have Dr. SALEEM Sharif, who is going to talk about Pakistan clinical research landscape. He is going to share his journey and discovery to serve at Pakistan Kidney and Liver Institute and Research Center. What are some of the challenges he faced and where he found opportunities? So I'm going to introduce Dr. SALEEM Sharif by I think what I'm going to tell it's very less of his introduction, but he is a Dow graduate from Dow University of Health Sciences, and then he did his residency fellowship in internal medicine, cardiology, critical care medicine, and then he has been working as an intensivist and internist at Grand River Hospital and at St. Mary General Hospital in Kitchener, Waterloo, Ontario, Canada since 2004. So during all these years, in addition to doing all the amazing clinical work, he also served in many administrative positions, including head of the Department of Medicine and health faculty appointment as an assistant professor at McMaster University Hospital, Canada. After doing amazing work in Canada, he joined back again in Pakistan at the Pakistan Kidney and Liver Institute and Research Center as an intensivist in October 2021. He has, like, if you look at his publication profile, you will see multiple scientific publication in peer-reviewed national, international journal, and he has wealth of clinical knowledge, wealth of research portfolio, and we are very happy that he is here to share with us some of his expertise. Before starting his presentation, I want to introduce you all with our panelist, which is Dr. Akhtar Hamid, who is a professor and pediatrician at the University of Toronto, Dr. Umar Hayat, who is again a renowned researcher, and Dr. Sarwat Hussain, who has also hold a immense clinical and research background. Last but not the least, I want to thank the Waleed to hold up all the technical part of it and supporting us throughout our webinar. Just to tell everybody, the webinar will be shared. And then also throughout the webinar, please continue posting your comments, your questions, either in the chat or there's a Q&A button down there. So you can put your question and we will try to take it toward the end of the session, like a 15-minute Q&A. And then this webinar video will be shared with you all in the WhatsApp group as well. With this, I will, Dr. Akhtar, Dr. Umar, Dr. Sarwat, do you want to add on something before we will start?
No, very good. Carry on.
No, thank you. Good.
Great. So over to you, Dr. SALEEM. You can share your screen, and we are waiting to hear all your amazing work and experience that you have and learn from you. Thank you.
Assalamu alaikum, everybody, and thank you for a very kind introduction. I hope you can see my slides now. Can you please? Are you able to see my slides?
Can you share it again? No, we are not seeing it yet.
Oh, I did share. Here it is. Oops. Are you able to see now?
No, you have to share it again from Zoom window. Just click green button, share.
That's what I've been trying. I'm sorry. Why I don't know. Previously, when I tested it, it was working fine. Waleed, can you help me here?
Yes, sure. There is a Zoom window. You can see the green button, share. Just click on that.
Yeah, that's
just
what
open the Zoom window, not the presentation. Zoom window.
Okay. Zoom.
Then there is a green share button on the bottom. Just click on that. Oh yeah, that's
Yes, we are seeing it. You can just put it on the slideshow.
Are all the slides there? I mean,
Yes.
you can see clearly?
yes, we are
Okay,
Yes,
good.
we are
sorry for
able
this
to.
delay.
No worry.
So
It
the
happens.
topic I've been assigned is Pakistan, my journey and discovery to serve at PKLI, which is Pakistan Kidney and Liver Institute and Research Center. It's situated in Lahore, and the challenges and the opportunities. So I'll try to be focused on the topic, and briefly I'll be discussing some of my experiences, and then what the ICU is, what the ICU life is about, because some of the audience might not be very much aware of the ICU, the inside of the ICU, I mean, how the program works and what difficulties and challenges that we face. Then the research opportunities and the collaboration. So these will be highlighted in today's presentation. So who I am? Basically, as Dr. Jabin mentioned, so I'll be very much summarizing here, starting from Dow University Health Sciences in Karachi, then did residency at Aga Khan University Hospital in medicine, followed by cardiology at NICVD. Then I moved for a year in Oman as a cardiologist, from there to Canada. I did medicine fellowship again in at University of Ottawa, and then critical care at University of Western Ontario, London. And I'm in the faculty of McMaster University, moved back to Pakistan and PKLI. This is the picture of our ICU in Kitchener, Waterloo area, the Grand River Hospital on the left side of the screen, and St. Mary Hospital on the right side. So people ask me quite frequently, what is ICU? Those who are not doctors, I mean. So I explain them that this is a place between life and death. So that's how I explain, because if there's no ICU, the people who get admitted to the ICU would have been all dead if there's no ICU. So we try to save the life. Obviously, in the ICU, there's a high mortality. Now, coming to that, before that, I want to explain some of the scenarios that we face quite much right from the residency in ICU and till now as a consultant. That quite much stresses that we face. Like, for example, sometimes you get call from the emergency that saying that there are a couple of patients who are critically ill, but there is no bed available in the ICU. That's a big challenge, how to arrange the bed, or to convince the other side to transfer the patient out to some other place. That's always been a challenge. Similarly, there are other challenges as well, like patients who are in shock and person who is dealing with is not able to find support from his senior if this or the system is down, and so on and so forth. So different scenarios over here, which explains what kind of difficulties right from the residency or as a consultant or staff member in ICU person faces now and then. So in summary, the ICU is basically dealing with multi-organ failure, and right from the CNS to other systems of the body which get affected, and person is in a dying situation where we kicks in and try to save the life. That's our main goal is. Using all kind of different interventions, and thanks to the modern technology that we have a number of intervention and facilities and equipments available which help us to try to save the life. Obviously, sometimes we are successful and sometimes we are not. So this is what we do in the ICU. So the concept of critical care historically, although it started from 19th century, but more specifically modernized into a specific intensive care unit in 20th century, when Danish anesthetist was the one who established the first ICU in Denmark in 1953. Since then, a lot of changes have been done in the ICU program. There are different models of the ICU, right from the open ICU to closed ICU nowadays, or in between, there were some mixed kind of ICUs programs that had been run. But now the ICU in the modern world, in the high technology areas, it's all closed ICU. So the closed ICU is basically under the responsibility of a trained intensivist. So he's trained and certified intensivist who basically runs the ICU in collaboration and cooperation with the allied specialties, the referring specialties, and if needed, some other specialties for consultation. The ICU, the closed ICU also contain a number of other staff members, right, from the nursing and allied health and technical support or the RTs. Similar, also importantly is the design of the ICU, the equipments in the ICU, the supplies, and so on and so forth. And obviously, the funding is required for all these things to run. So it's a bit quite expensive thing, which I'll be showing in some of the slides in the following slides. So the main objective of the ICU is to treat and try to save the life of the person and help the failing functions of the organs to revert back to their normal or near normal. And we try to save the life by potentially reversible condition. So the whole ICU team comprises, as I mentioned, it's led by an intensivist, followed by the whole team, including the residents, fellows, clinical pharmacists, nurses, respiratory therapists, and then some technicians, OT, PT, and all those members as listed in this slide. So they all work together under the supervision of the intensivist. And the intensivist is basically the person, it's a second fellowship. It's not the first fellowship. So the person like anesthetist, internist, surgeon, or the ER consultant, when they finish the first fellowship, if they are interested in ICU, they go for a second fellowship in the critical care. And then they become the intensivist and so on. So the benefit of closed ICU is working as a team and taking the ownership of the patient. So that is important because in the open ICU, other persons, if, for example, a patient of a nephrologist got admitted because of AKI, and now he has other problems as well, for example, MI or any neurological deterioration or GI problems, then they are running around to find other specialties to manage it. But there is no one to oversee everything together and then putting the things management together and taking the ownership of the patient. So that's the benefit of the closed ICU, where intensivist basically not only just collaborate, but also manages and takes the responsibility of the patient care. So this has proven a number of studies that closed ICU has decreased the mortality and improved the outcome of the patient. Also, it has decreased the cost of the treatment as well. So this slide, although I labeled it as how it functioned, but I would also call it as a world of ICU. So right from the caregiver's quality of life, communication with the families, post-ICU syndrome means when the patient is discharged from the ICU, sometimes they have a bit more confusion, delirium lasts a bit longer, the quality of life get affected. There are ethical decisions that needs to be done in critically ill patients. That means whether or not to continue the life-sustaining interventions or to withdraw if there's a brain dead or poor quality of life. Also in the ICU, it's also important to see in which patients you have to intervene and in which patient you should not be offering all these heroic measures. So this is all the dynamics that we do in the ICU, plus obviously the research things, and all these things cost a lot. That has to be funded by the government and so on and so forth, or public-private partnership. Different levels of the ICU, it's important to understand because it's not just like, for example, in Pakistan, as I mentioned, here the people haven't got much information about the level of care that is provided in the ICU or how the ICU functions. And there are some very good ICUs, but what I'm talking about is the general public. So the patients who can be generally managed in the normal wards are level 0. And sometimes they need the consult from the intensivist. They go see the patient. They think the patient does not need critical care unit. So they advise whatever is needed for the patient and over to the primary physician. Level 1 is the area where a bit more support is needed for a patient. But the thing is, for example, telemetry is required. But the patient is not critical enough to have more advanced technologies or interventions required over there. Level 2 is a bit more higher up. And if there's one organ failure, the patient needs level 2 ICU. Then it comes the level 3 when there is more than one organ failure or a multi-organ failure. The patient require more complex support and management. So that is the level 3, which is the highest level. So in the ICU organ support, that means respiratory, which requires ventilators, and cardiovascular, which require not just the vasopressors, but sometimes pacemakers or ECMO, and these kind of technologies are needed. Then neurological, in which not just neuromedicine, but neurosurgical patients, and so on, so there are specialties. So goal of ICU, as I mentioned, is to reduce the morbidity and mortality in critically ill patient and to salvage the organ function, restore the health. So this is all that is done in the ICU to improve the patient's condition by providing life support. The management and continuous monitoring of the patient aims to restore the vital function and reduce the mortality. So the mission statement for the ICU, you might see in different ICUs, is to provide the best possible care throughout constant close observation of patients with acute critical illness condition, to immediately recognize potentially life-threatening complications and promptly institute indicated treatments. So the studies have done that, if intervention is done early or late, what could be the impact? Because in some hospitals, especially in third world countries, people have different kind of, mentality in general public or in the healthcare system as well. They think that, ICU may be more costly, which is true. And in order to save the cost, they delay the involvement of the intensivist or the critical care or to transfer to the critical care unit just to save the cost. But this has been seen in the studies that delay admission to the ICU, in fact, really increases the mortality. As you can see in this slide, the mortality increases quite much as the time passes. If the immediate intervention is done, then it's like 37.6%, and it goes on more than 24-hour lapse, make it like 57% mortality. So here again, in this slide, you can see the delay admissions. There is no difference between survivors and non-survivors in terms of mortality. Both are high. While in immediate, you can see that, survivors are quite more as compared to the non-survivors who passed away. Also important to see and realize the age factor of the patients. Younger the patients are more prone to survive versus elderly patient. So it's not just the age also, but you have to see the baseline status of the patient, the health status of the patient, the comorbidities, how good the patient was at the baseline. And then you decide how aggressive you need to be. Challenges. So the purpose for this outlook, giving the outlook of the ICU, the way it functions and the system is, so that now we can understand the challenges that is encountered in the ICU atmosphere. So the challenges I've divided here into different categories, like physical, emotional, professional, environment. These are all environmental factors, plus social stresses, increasing workload and physician burnout, which is very important, which I'm going to discuss in detail, and increasing the cost of critical care, and finally the tele-ICU. As we all know, the workplace stressors include sometimes unfriendly and annoying behavior from whether your juniors, whether your colleagues, or whether the staff. Sometimes it gets very much frustrated when the intensivist sees that things are getting delayed and people are not as fast in reacting or addressing the issues which the intensivist wants to. So this all causes stress to the person who is taking the responsibility, because as I mentioned earlier in the previous slide, the time is the main factor. I've seen in Pakistan, and this is one of the challenges, that, people are a bit slow to respond and they don't realize the importance of the time as compared to when I work in Canada. Time is the main factor. Everybody knows that, once you start saying that this patient is critical and we have to address very quickly, things goes very fast over there as compared to in third world countries. So now ICU also provides services, as I mentioned, to the sickest patient. The mortality is always being on the higher end. So you have to be emotionally strong to address the mortality, because it's not just yourself, then the patient and their family, the whole atmosphere in the ICU gets sometimes depressed when there's a sickest patient dying in front of you and you're trying your best to save the life, but sometimes you are not successful. Now, number-wise, the mortality is always high in the ICU. As I said earlier, that you get the sickest population. Those people are already dying, and you are trying to save the life. In the best centers in the world, in the Western countries, the first world, I would say, the mortality in the ICU ranges between 9% to 18%, which is significant as compared to the middle income or low income countries. The mortality, like for example our country, the mortality ranges from 20 to 30%, sometimes a bit more. But in more poor countries or underdeveloped countries, the mortality is as high as 50%. So this is a high mortality in the ICU that you see, and obviously this reflects from first world to the third world, reflect the training, the funding or resources, as well as the facilities that you have. So professional environment is also important, because sometimes you see, other colleagues are not understanding the stress that the intensivist is facing. And, I quite often, get this impression from others, other specialties, that, oh, we also do the calls. So what's the problem when the ICU person is doing the call? But there's a huge difference between the call that an intensivist does versus the call with other specialties does. Because in the other specialties, if their patient gets sick, they refer the patient to the ICU, and then their headache is over. It's all over to the intensivist who is there. And believe me, if it's just even a one very, very sick patient comes to the ICU, it will take a whole day in stabilizing that patient, resuscitating that patient, putting the lines, and so on and so forth. It's quite much stressful work that is done over there. Long hours, stressful, these all leads to the burnout situation. So this I already covered this slide. Now, social factors are also important, because the thing is, all this comes on to the person that is intensivist, and he is dealing with the families of the patient, explaining them. And some are very well educated who understand the sickness of the patient and take even the bad news very well. But there are people who wants everything to be done, and they quite often say that, oh, he or she is a vet. And even as a 95-year-old or 80-year-old, he is a good fighter and he'll come along, not realizing that it's a multi-organ failure and person is dying. So every life ends with the death. So death is imminent in everyone. We all have to die one day. And the way I explain to the patients and their families is, we all have to die, and there's only one of the two way a person dies, either by the accident or by the sickness. So in the ICU, we see both. Like we get trauma patient, we also get sickest most population. And then we try our best to save, but as what I would say is, we can try to save the life, but we cannot give the life. Life can only be given by Allah. So the leader needs to encourage the workers to admit and deal with the stress rather than attempt to ignore it. Organizational approach to deal all these called stresses, and the working hours need to be reasonable, and to understand your juniors also get fatigued and taking all the stresses, whether they are junior doctors, fellows, residents, or even the nurses. They are doing a very good job, and in the ICU nurses are the anchor people. They are the backbone of the ICU. They are in a very much stress. And 1:1 nursing in level 3 ICU is because there are so many things that nurses have to do, which leads them also to the burnout situation. Like the hospital I work in Canada, we are these days facing the problem of burnout right from the physicians as well as to the nursing staff. So, as I was just saying that, this overwork leading to the burning out situation, and the working hours needs to be manageable so that one can have a good quality of life. There was a Canadian survey which revealed that 50% of the physicians do not feel that they have balance in their lives because of excessive work demands. So those who are in North America, they are very well aware of this type, the physician burnout problem. Quite many get burnout in their early 50s. Quite many of my colleagues are deciding to retire early because they have got burnout due to excessive workload, stress. All these things lead to their emotional exhaustion, depersonalization, and reduced feeling of personal accomplishment sometimes. And because the thing is, you work hard at your best, and there's no such appreciation from hospital, or sometimes from the families or your own family. People don't realize how much stressful work you do. And some people think, like in US, most of the ICUs have shifts of 12 hours for the intensivist, like from 7 a.m. to 7 p.m. and from 7 p.m. to 7 a.m. In Canada also, more or less similar kind of. And those closed ICUs are run primarily by the intensivists who are in-house all the time. In Pakistan, it's a bit different, and we don't have to be in-house all the time, but we have long hours. We have to be available. We have good team over here to deal with the patient, which I'm going to discuss in my future slides. So, so the reasons of burnout I've already explained. This is a high demand specialty, which leads to all kind of stresses. So I'll skip this slide. And beside all these things, they are quite much, attractive and rewarding ICU work because saving life is the most important thing that one can do. I tell my juniors, you can earn money from anywhere. Like, you can do business, you can go to any other profession, which may give you more money. And you may make more in less number of working hours that you spend in ICU or as a healthcare provider. But the thing which you gain or you earn, basically, beside money, is the prayers, the good wishes, then the good sentiments, and all those things from the families of the patient. And, when you see a patient who was initially admitted to you in a dying situation, unconscious, comatose, multi-organ failure, on dialysis or CRRT or ECMO and all those kind of vasopressors, and with your all efforts and the grace of Allah, the patient gets better and walked out of the hospital. So that, feeling cannot be explained in words. So that's the best reward, I think, one feels like. So there are challenges to the ICU leaders, which I've mentioned just now. And in the end of it, like, it's rewarding that you feel good when you go home, that you have done something good to save the life of the patient. Got stuck here. Okay. So now coming to how to improve the working environment. There are 6 essential things that needs to be addressed upon. Skill communication, collaboration, effective decision-making, appropriate staffing, meaningful recognition, and authentic leadership. All this revolves around the circle, and there's no alternative to skilled communication. When you talk to the people, even the bad news can be, addressed in a very proper way that the person on the other side can take it positively and accept the bad outcome. Similarly, the collaboration within the ICU team, as well as with the other specialties, those who are involved in the care of the patient, is important. Plus, involving the family of the patient is very, very important, that to keep them updated about what's going on with their patient and what decisions are going to be done. And especially when you decide about withdrawal of care, then that's the most important part in somebody's, in someone's family, to decide to switch off the machines and let the person go. So this is very important where you need the good skills for communication. Now, coming to the cost of the ICU, it's a high cost area, as I mentioned earlier, and there are a number of studies that has been done, mostly obviously from USA, and they have explained the cost in billions of dollars in the ICU, and that cost is increasing every other day. Like between 2000 and 2010, in just 10 years, the annual cost of critical care medicine increased 92%, like from 56 billion to 108 billion dollars. And this is going to increase further in the near future. This is another study in which they have divided the cost over per bed, like $2 million per ICU bed. And then the whole ICU cost, like 80 billion per year. These are quite a high cost for the ICUs. Now, how this cost can be reduced is the question. So the intensivist-led ICUs have seen not only reducing the mortality, but also have reduced the cost. So this is a bit repetition, as I mentioned already. So here's the division of the cost. This study is from Vietnam, explaining the different cost that is involved in the ICU, right from the equipments, including the pumps, ventilator, dialysis machine, monitors, and ultrasound machine, plus the staff cost, and so on and so forth, as you can see. These are all costly things. So possible cost saving measures, up to 1 billion per year cost is there in most of the patients. Mostly the patients are from severe sepsis, ARDS, and different kind of intervention that we do. Use of 24-hour intensive staffing has several advantages, including decreased cost, because they know, they are trained in deciding what kind of interventions to be done and when not to do, and when to stop, unnecessary investigations and unnecessary interventions. Also, they also decrease the mortality and morbidity. So all these measures are important in decreasing the cost of the care. So tele-ICU is comparatively a bit newer thing. It started from the USA. Everything mostly nowadays starts from the USA, and they are the trendsetters. So this tele-ICU has, come up with the idea that even there are quite many places which are remotely located, and the intensivist hiring an intensivist is not easy. Plus, not just the hiring, the retaining an intensivist is also difficult. So the tele-ICU is a place in where there's a continuous communication provided by an intensivist who is remotely, geographically located remotely, and advising the staff over there at the bedside of the patient. And one intensivist can monitor and control, more than one ICU at a time from remotely. But obviously, you need a trained staff in local ICU who can follow the instructions. And then there's a good communication is required between the intensivist who is sitting remotely and running the ICU there. But that helps especially in remote areas. Plus also, this has decreased the cost. Like instead of, like for example, if one intensivist through the tele-ICU is running 3 ICUs, so instead of hiring 3 intensivists, you have one intensivist who is running 3 ICUs while sitting remotely and advising all the local teams how to manage the patient and so on and so forth. So This obviously need good technological support and good understanding between the team members so that ICU can be run smoothly. So these are all infrastructure things like a high definition camera, good internet connections, and the staff needs to be cooperative and so on. So challenges for smart ICU is like tele ICU, is there's availability of the critical care expert is still not much available. Who runs the ICU? Some people think that running tele ICU is very easy. It's not. Something that they are running from home, so they are just relaxing. That is not true. Sitting for 12 hours in front of the computer, you cannot go out. You cannot move out, and you have to take the responsibility of a few ICUs and running them. So it's not easy. So it's pretty high demanding, and you have to have a good connection, as I mentioned earlier, and good team so that they can understand. So now this is the geographical distribution of the high income countries versus low income and poor income countries. The reason I'm showing this because ICU, as I mentioned in the previous slide, is an expensive area. Running an ICU, establishing an ICU is really expensive, costly, and not all countries are wealthy enough to spend billions of dollars in the ICU. And unfortunately, the third world countries have more population as compared to the first world countries who have more resources than their population. So this is a bit disparity between the two things. And tele-ICU, to some extent, give the answer. It might be more uh, well managed. It can be more well managed in the third world countries because you have less number of intensivists and more population, less number of proper ICUs, and less trained staff. So with the tele ICU, one intensivist can control more ICUs and advise them accordingly, rather than there is no trained person, and the person is just, patients are just dying. So barrier to access in developing nations, and the hospitals in developing and underdeveloped countries often find it challenging to provide treatment and therapies due to the high cost, as I mentioned earlier. And this is again, this cost include pumps, IV pumps, monitors, ventilators, medications, then the staff, whether they are technical staff or whether they are doctors. All this, increases the cost. So the challenges, obstacles in which the low-income countries faces are people in which, as I said, trained staff, then the processes, they need proper training to do right from establishing the unit to have protocols of different treatment management, as well as care of the patient, the bundles which we use in the ICU care bundles, hand washing, all those things, and then the technology, the high-tech things, right from ultrasound in the ICU with the focus trained staff, plus you have TEE or ECMO and all those things. So ICU is the place, as I mentioned, we try to prevent the deaths. And in 2016, an estimated of 8.6 million premature deaths occurred in low-income and middle-income countries from the causes which should not lead to the death. So that's why I use the term preventable death, that those people should not die. And just putting a statement that, it's their, it was in their destiny to die. That's not really true. So there were quite many patients who could have been saved if proper intervention was done on time. So what made me move back to Pakistan? After years of training and working in Canada in very good centers with very good colleagues and teams, life becomes more easier there. And then I thought that, okay, maybe it's the time to give back to my own country. So that was my main reason to come back to Pakistan, to transfer what I have learned to the juniors over here, so that the ICU here can develop more. There are quite many other people like myself who have moved back to Pakistan from different parts of the world and serving here and doing an extraordinary job in different specialities. So as I mentioned earlier, in Pakistan, unfortunately, the concept of ICU is very scarce, and people doesn't know much about what ICU does. As I mentioned earlier, that I explained to them that ICU is a place between life and death. So the people who get into the ICU are in a dying situation, and we try to save their life. Now, there is a still need for critical care services in Pakistan, more and more need, basically. Quite many ICUs in different private or public hospitals are, unfortunately, it's a bit shame to say, shame to call them as ICU. They are just in one room, patients are there. There's a board outside that it's an ICU, which has nothing like an ICU inside. So this culture needs to be changed. But obviously, there are places in which they are very good ICUs. But unfortunately, there are not many trained intensivists in Pakistan. There are only few in some very good hospitals. So this is a big challenge to have highly trained intensivists around and to hire them or to keep them. For example, in my hospital, we are trying to recruit more intensivists, but we are not getting any luck to find well-trained intensivists. So these are the stresses that not just our hospital is facing, but quite many countries in the third world are facing. Plus, financial issues to run the ICU. The budget is not much given to the ICU, and then how can you hire more trained staff, whether they are doctors or nurses or technicians? So what needed is a good leadership support. That means genuine and substantial support from the local and state level, involving both political and health authorities to create a good ICU environment. Because it's not just one-time investment. It's after the first investment to establish the ICU for its infrastructure or equipment, but then you have a running cost as well to maintain the things and to upgrade it accordingly as the time passes. There was a good study, I think this was done in Afghan Hospital a couple of years ago, and they have involved number of ICUs and to survey, found that Pakistan has an underdeveloped critical care network with significant inequity between public, private, and metropolitan rural area. And they hope that in the future this might be solved, but obviously that requires a number of steps to be taken. So in these studies, they have interviewed more than 100 hospitals. And in this slide, you can see all over Pakistan, different hospitals were contacted. They address how many number of beds were there, how many beds in the hospital, and then how many beds in the ICU or step-down units, how many ventilators, and so on and so forth. And quite much depressing that some hospitals have good numbers, but most of the hospitals, the number of beds versus number of ICU beds, there's quite much disparity. Here again, then it's all what kind of facilities are provided in those hospitals. It's pretty much, in different hospitals like private and public, there's a disparity between them. In the private hospitals, you can have some facilities, but in government sector, I may not need to say much. Everybody knows that what the condition of the government sectors, except for some few hospitals. Again, it's a bit depressing to see here, as shown in this slide, the qualified staff, whether they are intensivists, nurses, or technicians, there's a scarce availability of all those in our hospitals. So out of 106 hospitals that were surveyed in these studies, they found infrastructure, staffing, and system lacking. Only 19.8% of the hospital had negative pressure rooms. 44% had quarantine facilities. Across the board, there's a shortage of nurses and intensivists. Only 36% of the hospital had one qualified intensivist as a consultant in their ICU. So this is like, that means 64% of the hospitals have no intensivist at all. And other specialties are just trying their luck to treat the patient and so on and so forth. 54% of the hospital maintained an ideal nurse to patient ratio. And this half number, that means half of the hospitals were not even maintaining the nursing, not able to provide proper nursing. 31% of the hospital did not have a staffing model. 37% hospitals did not have such policies. There was a significant difference noted between public and private sectors, along with metropolitan versus rural settings in various elements. In the rural areas, the conditions are more devastating, and in Pakistan, most of the population is rural without any proper healthcare facility. So this is PKLI, Pakistan Kidney and Liver Institute and Research Center, which I joined in October 2021, 3 years from, it's 3 years now. At the right bottom, this is the picture of our ICU, one of the ICU room. So PKLI was inaugurated in 2017 as a specialized healthcare facility dedicated to patients grappling with, struggling with kidney and liver diseases. And so far, our hospital has performed more than 800 kidney and more than 700 liver transplants with a living donor. It's a quite good number. In Western countries, you have cadaveric transplantation available. Unfortunately, in Pakistan, we hardly had, a couple of cadaveric transplants done so far. There are a number of issues for the cadaveric transplantation. The number one issue is the education to the public. It's very difficult here in culture-wise to ask anyone to donate their organ. If the person who is dying, brain dead, you ask the family that, okay, this person is brain dead. Can we have the organs for someone else to, be treated for? The feedback will be very negative. So at PKLI, our ICU, we have a separate surgical and medical ICU. And the reason for a separate medical and surgical ICU is because our main population is transplant patients for both kidney and liver. And these transplant patients, we keep them a bit isolated. All patients have separate rooms, and very good isolation is provided so that infection should not spread from one room to the other room. In medical ICU, you have more medically ill patients who are more of septic in nature, more populations of sepsis. And in Pakistan, you get quite many multi-drug resistant patients. So that's why we kept the medical ICU separate from the surgical ICU so that the transplant patients who are on immunosuppression could be safe from, MDRs. Then we have a step-down unit, which we currently having 6 beds, and hopefully we are going to increase the number of beds from New Year. And by mid of next year, we hopefully be opening up our 3rd ICU. It all depends upon the staffing, obviously, and funding, but that's our plan for the future. So, what is the research problem that we have here? There are a number of things. Number one is the culture of the research, and number 2 is the funding. So these are 2 basic problems, and the culture of, to develop interest in research as well. At our hospital, we hope to complete the following objectives in the near future. Serve as a bridge between faculty and residents for research opportunities, maintain a database for ongoing researches, build a build and maintain database for research electives. We are going to start a medical journal. Hopefully, our first issue will be released in December, and hope for the good. We are right now collecting articles. If somebody wants to submit any article, they can visit to our website of PKLI Hospital, and you can find how to submit an article. We are in the process of its recognition from PMDC. So right now it's not PMDC accredited, but hopefully there's a whole process through which we are hopeful to get recognition pretty soon. Our aim is to initiate research studies to enhance national research output via multi-sector collaboration. We are open for all kind of collaboration from any part of the world. And we want to train our new doctors in ICU or in the other specialties in the hospital, mainly liver and kidney and gastroenterology, and transfer the knowledge to this young generation. What I have done so far in the last almost 3 years, overall published a few papers, and during the last 2 years, I've already published 6 papers, and ongoing, I have 8 ongoing projects at different stages of writing up, data collection to write. So hopefully in next 1 year, I have addition of 8 more publications. There are quite many other doctors who are also involved in research at our center, and they are doing a good job and publishing papers. So opportunities, the challenges for critical care in developing countries are numerous, as I try to illustrate. By developing cost-effective and compact ventilators suitable for resource-limited settings and incorporating telemedicine and remote monitoring system, access to critical care can be significantly improved. And so as the cost can be decreased as well. I heard recently that there are some local manufacturers in Pakistan who are trying to build up ventilators, and they were in the final stages when I spoke to one of the person who was the owner of manufacturing company of different equipments, and they have developed the ventilator. It was in a process of approval from the government. I don't know it has already been approved now or not, but when I spoke to him last time in a meeting, he mentioned that he is in a final stage of getting approval. So that would obviously decrease the cost because ventilators cost a lot. Similarly, there are a number of other things like right from central line, dialysis catheter, and so on and so forth, which are imported. I'm not sure why they cannot be manufactured in Pakistan. In India, they are manufacturing everything, but unfortunately, we are behind in manufacturing things, and we are just importers. So if local industrialists develop start manufacturing these things. We manufacture surgical instruments and export all over the world. So why not these things can be developed here? Also, now development of tele-ICU in Pakistan. There are people in Pakistan who does tele-ICU while sitting from Pakistan. They provide services in USA, but this has not been developed within Pakistan. The concept is not there. And when I have spoken to some people about developing tele-ICU, and they just look to me like what I'm talking about. So there's no concept yet about tele-ICU in Pakistan, but we are trying, and hopefully it will, someday it will develop, which will help in the remote areas as well. So as I mentioned, tele-ICU needs to be developed in Pakistan to help the remote areas and provide good care to the patients who are unable to come to the major cities of Pakistan. So goals for the future, a hospital in a process of recognition as a teaching center from PMDC. Although we are already a teaching center, our gastroenterology program is recognized by the CPSP. Nephrology program is recognized. I think hepatobiliary surgery has recently been recognized. internal medicine is recognized. But I was surprised to know that as a whole hospital, somehow PMDC did not give us the label of a teaching center. So I don't know what is the problem there. But we are looking forward in the next few years to develop into a university model for which we need support from the PMDC and CPSP and obviously from public as well as other healthcare people. Funding is obviously needed to run the show, to get the equipments, and then we are open for collaboration with international universities to start research work here. We are developing a system. We hired a biostatistician as well. Recently, we have a good IRB system, like all my publications which I mentioned have gone through proper international process of IRB approval. So we keep all these things and confidentiality of the patient and so on and so forth. It's all in place. So we are a good center to establish some collaboration internationally. So in summary, improving the quality and availability of critical care is essential for reducing the burden of preventable deaths. Currently, high costs severely restrict access to critical care in low-income and middle-income countries, including Pakistan. By leveraging innovative solutions and fostering partnerships, it's possible to enhance healthcare. Tele-ICU and telehealth may offer part of the solution and make it more affordable, and remote areas can be covered very well. In Pakistan, remote areas, there is no shortage of it. You know that. The future may be uncertain, but we are hopeful that with the support from the public, with the colleagues and so on, we'll be able to achieve our goals and set up a stand. Thank you very much.
Thank you so much, Dr. Saleem. Sharieff, can you please unshare your slides so that we can see everybody on the screen? It's a very, very enlightening presentation, and thanks for taking us to a journey of ICU for an hour. I'm a pediatric emergency medicine, so I can echo some of the emotions. There are huge comments and there are a couple of questions, but before going to that, I know we are at 2-minute mark from the end of the session. Why don't I go to our panelists for their comments and any particular aspect they want to talk about. Let's go to Dr. Omar Hayat first.
I don't have a question, but rather a comment head to you. I mean, what you are doing, that's amazing. I really want to say we must encourage our local manufacturer. I know there is a dialysis machine also being developed by one of the companies, and I'm aware of the company you are talking about for the ventilators. The other thing, I have been to a few conferences. One thing we really need to look into is the data sciences. I mean, there is a lot going on there, and the artificial intelligence and benchmarking some of the practices and interconnecting all the ICUs existing within Pakistan. So I will stop here, and thank you very much, Dr. Saleem. Wonderful job. Thanks.
Thank you so much. And I want to mention, Dr. Saleem, Child Life Foundation has created a telemedicine for pediatric emergency medicine. If you want to connect, they have a huge infrastructure and they have built such an amazing telemedicine for pediatric emergency medicine. And they are sitting in Karachi and they are managing like all over the Pakistan in the remote places. So maybe connecting with them, I'm happy to connect you, or Dr. Akhtar knows them well as well. They can connect. So maybe an opportunity that leverage their infrastructure and learning and to start developing the tele-ICU as well.
Sure, that would be very helpful.
Yeah, Dr. Akhtar.
Yes, thank you, Dr. Saleem. You happen to be my class fellow as well. So I have the leverage to ask a couple of questions in a way that, I mean, you know the Canadian training of ICU. So me being in Toronto and you know the Canada, I think we should put a task force who can go and talk to our colleges here, CPSO, where we can bring some residents or who is interested in taking fellowship training and we can try to collaborate some training facilities, 1 year or 2 year clinical training for ICU. It will help get some of the potential ICU trainer who can get some abroad facilities, and they can come and do some great job which you are doing it. Not everybody is has this brave heart who leave the facilities like Waterloo, which is a very good center, and going back to PKLI and trying to help and support our institute. And second thing is, yes, we need to develop a culture of our research, and for that maybe in future we can sit together and bring some some institute who can easily collaborate with such a institute like PKLI. Thank you.
Thank you, Dr. Akhtar, for your good comments. And I know you have involved very much in collaborating with different centers, and we'll look forward towards you as well.
Great. Dr. Sarwat, do you have something to add?
Yes,
please?
I have actually a very quick comment. I know that we are running out time. The question is that obviously the ICU is a very cost-intensive operation. Is there research going on to bring the cost down in order to use some indigenous medication and instruments and equipment, etc.? Because that will bring into the access to even less affluent society.
So I missed your last part of the question. What was your main question? Hello?
To bring the cost of the cost down in order to bring the access to less affluent people.
Yes, so to bring the cost down, there are two things in the cost-wise. One is the infrastructure. The other thing is the supplies to maintain that infrastructure and the medicines and so on and so forth. And the third is the staff. That includes not just the intensivist, but the allied health and nursing staff as well. Because the nurses in the ICUs are paid more as similarly, you need RTs and so on and so forth. And they are paid more because their work is more stressful and they need more training and more expertise. Similarly, intensivists are paid more as compared to the others, not as compared to the surgeons, but these are the costs. But as I said, in a country like Pakistan, if we happen to develop a tele-ICU, that would be very helpful. Because it's not just the money that you spend and you'll get, you don't have many intensivists available. As I said, we have been trying to recruit more because two of our very good intensivists left for different reasons. And we are short of intensivists and our workload is increasing. And just myself and one more intensivist is left over and we are burning out. So the thing is, we want more people to join our group, but we are having difficulty in recruitment. So this is one thing because there is not much intensivist available, and those who are getting trained in Pakistan, unfortunately, they lack resources as well. I won't criticize their trainers because there is a lack of resources as well. So this is all goes together. So in terms of reducing the cost, obviously, if the local industry, now the government has to kick in here to encourage the local pharmaceutical industry and the manufacturers of the equipments, whether they are ventilators or other equipments, which I mentioned in my presentation, if they are locally manufactured, then that would be a huge impact on the cost reduction. So these are all, number of pieces has to be put together.
I would like to second your idea of ICU thing, even in Western countries like America and Canada. Dr. Jabin is aware of that we have started with the collaboration of Mayo Hospital, tele and ICU, the first hour resuscitation. And that is, as you know, that we don't need our ICUs are well advanced, well-trained people are there, but still we are working on that, doing some tele and ICU in terms of newborns for first hour, for premature babies, for very sick babies just after the delivery. But countries like Pakistan, where we have, as you said, less trained doctors, resources are less, but at least you can provide one doctor can help many centers, one together.
Great. I think there's a loads of enthusiasm going on. Their comments are just flowing like anything. At one time, there was 81 attendees, so that is very good. There are a few comments about like helping to train some ICU staff in Afghanistan as well at MOPH Kabul, something for you to look at. And then Dr. Saleem, there's a comment by Fahad, and he's saying that we at PHC looking forward to work on together on tele ICU initiative. Also, there are some clinical questions we will share with Dr. Saleem, and he's happy to answer. Send us the answer, and Waleed can share it on the WhatsApp group. So thank you everyone for staying 6 past the time that is allocated for these webinars. The recording will be soon available. Waleed will be sharing the recording on the WhatsApp group, and also you will get your certificates as well. Yes, Dr. Saleem, please go ahead.
I appreciate a comment coming from, I think Dr. Ehsanullah. I'm just reading from, to help in Afghanistan. Obviously, we are a healthcare provider, and healthcare provider has no boundaries. And we are, open to, collaborate with any part of the world, including our neighbor Afghanistan and Central Asia and so on and so forth. Wherever is needed, I think tele-ICU needs to be developed in this part of the world and to expand, not just in the, rich countries. It has to be, third world countries will be more beneficial.
Yes, thank you, Dr. Saleem. Can you, if you are okay, share your email address with Waleed, and he can be able to share with the group, or you can put it in the chat. With this, thank you so much for spending your weekend, your afternoon and evening in Pakistan, and quite late night with all of us. Yes, Dr. Omar, you have something to say, add on?
No, I just want to say thank you.
Perfect, great. And once again, thank you, Waleed, for helping us with the tech part and running it so smoothly. I would say a huge thank to our panelists who have taken time from their busy schedules. It's life, it never stop, but they never stop, like it never hold them to attend these sessions for us being together to learn and then to collaborate and to make things better for our country, for everywhere we are working and living. Thank you so much with this. Have a wonderful weekend, wonderful night, and wonderful evening. Thank you so much. Allah Hafiz. Take care. Bye-bye.
Thank you very much. Bye.